Small session, like another 1 minute of questions and answers for the previous speakers. Can I invite these previous speakers to please come up to the podium to answer questions? And after this, we have a keynote speaker, which Dr. Nezhat will introduce, Dr. Farr will introduce. So kindly come up, and I'm going to start off with one question. This question is addressed to Dr. Maurice Chan and Dr. Enrico Chan about the pain management. This pain, pelvic pain, which continues to persist after hysterectomy, after treatment, excision, is it because of the neuroplasticity, or do you have any special treatment? Does it eventually go away?
Well, it's a very difficult question for me. But anyway, before I do surgery, I pretty much figure them out what kind of pain they have. That's the algorithm. So if it's an IC patient, well, I can't call them IC, okay? IC is pure urothelial disorder. But many of these patients have partial urothelial disorder combined with pudendal nerve problem and myofascial pain. So when you do the anesthetic challenge testing, when you put anesthetic into the bladder, the pain is completely gone. That's even before surgery. Well, I'll do surgery. I found that she had endometriosis and excise them. And I'll tell them, when your pain comes back, it is not your endometriosis. I don't think I'm just a terrible surgeon. I think it's you did not follow your diet, and then the pain comes back. For patients that have a combination of pudendal nerve problem, remember sitting hurt after the childbirth, the ligament get torn, the pudendal nerve get injured, and she also has some urothelial disorder. So I can tell from the anesthetic challenge testing, once I put it into the bladder, how much improvement. Okay, half of the pain is gone. The other half of the pain comes from pudendal nerve. Then I take them into surgery, and the pain comes back, and I know what to do for them. Will they ever come back? Yes. Mark my word, they'll come back with chronic pelvic pain patients, depends 6 months, a year. Some of them will just come right back within 6 weeks. If the pain gets worse right after surgery, you know, the problem is not so much about endometriosis. I know I removed them all. Did I answer your question?
Did I do? Yes, thank you. Do you have a take on this pain management after everything has been done?
So I think as I mentioned in my talk briefly, expectations, preoperative expectations between the patient and the surgeon is extremely important to be discussed at length. Meaning what? Meaning that I never ever tell a patient that I can guarantee you that after the surgery you will not have pain. Because that's something that I cannot guarantee. But it is part of the process. Surgery is at times needed, and it is part of the treatment, surgical treatment of endometriosis. And not only that, but surgery itself does provide more information that maybe before we did not have, such as, for example, painful bladder syndrome, interstitial cystitis. Since majority of my surgeries, I also perform a cystoscopy to take a look at the bladder, inside the bladder. So again, I think patient expectations is something that we have to emphasize more and more because it does play a key role.
Thank you so much. Does anybody have a question in the audience? Then I have one question for Dr. Furo.
Saeed, ask a question here.
Oh, so, I'm sorry, I couldn't see you. Go ahead. There's a mic behind you.
Good morning. My name is Roland Brutus, and I study medicine. During one of the previous presentations, it was highlighted the complexities of the surgery of endometriosis was highlighted, and it was mentioned that it can become even more complex than oncological surgery, given the degree of inflammation. My question to you is, to one of you whom I want to answer, is what motivated you to tackle such complex surgery? What gave you the courage to do so? and what motivates you to keep moving forwards when complications arise?
I think this was a previous speaker. We're talking about this session currently. You have any questions about this session? Otherwise, a general question, you can find him in the audience and speak to them. Dr. Nezhat, Nezhat will tell you. They can speak to you maybe in the next session.
Okay, thank you. Yeah, you're right.
I have a couple of questions.
ahead.
Regarding microRNA, what is the source of microRNA, and can we use that as a predictive value to consider people who are positive to have endometriosis in future? And I have another question about pain.
Sure. So yes, so essentially those markers were developed in previous studies on patients diagnosed with endometriosis via laparoscopy. So the particular study that the markers were from the saliva of patients. It definitely has a significant impact for the future as far as a potential diagnostic modality. The results so far are great, are amazing, to the point that I believe that certain national, I should say international colleges, I do believe that France has actually incorporated microRNA from the saliva testing as part of their algorithms when they look at endometriosis. So the results are great, but again, there's still much to look into.
Thank you so much. We have just 3 minutes left. And
Another question about pain. In those patients who have recurrent pain after surgery or treating IC, did you look at the markers of inflammation such as tumor necrotizing alpha or interleukin-6 or C-reactive protein?
Yes, it would be great to have a marker. Unfortunately, we do not have these markers have been looked at in research studies, and they are applying mainly to research subjects. So in the past, there was anti-proliferative factor, which showed extreme potential for this. I think it was from University of Maryland, and then they were getting embroiled into patent issues. The potential for the markers are immense, because you can imagine all of these patients with endometriosis with chronic pelvic pain will automatically get a urine test, and this would be universally used. So the potential financial benefit for whoever comes up with this marker is enormous. That's why my understanding is that one of the challenges is the patent issue. So we don't have one yet, unfortunately, but we look forward to having one because it would be immensely useful. I think it's for these patients with chronic pelvic pain, even diagnosing them with something would be extremely reassuring for them to reinforce their symptoms, to come, to also rule out cancer, right? A lot of patients are worried, do I have cancer? So giving them a diagnosis is immensely useful for them, reassuring, and once you find the diagnosis, whether it's endometriosis or chronic pelvic pain associated with bladder syndrome, following conservative management, in my experience, I've seen more than 80% improvement of patient symptoms with simple things like urge suppression techniques, behavioral modifications, dietary modifications, and occasionally bladder installations.
Thank you so much, Dr. Bogdan. We have 1 minute. Last question, anyone in the audience?
I have a question going back to the postoperative pain management. I personally, as a patient myself, have gone through Botox injections around my anal sphincter and everything, as well as I have 2 spinal cord stimulators for other injury, but I have noticed that it has helped a lot with some of that lower pelvic pain and the Botox injections. Although they only last about 3 months, there is a lot of relief there. So I didn't know if you guys had any experience with those specifically.
Well, as I said before, I pretty much know exactly how I can get the patient's pain better before the surgery. And I actually would tell them if it comes back, what do we do? Some patient needs intravesical therapy and the pain's gone. Some patient needs pudendal nerve injection along with Botox. Because when you have Botox, it's the muscle reacting to the pain and muscle spasm. So muscle never forget, no matter what you do. So either you use Botox or you go to a physical therapist and do multiple sessions of physical therapy, and it's just because the brain never let go. I hope I can help you.
Thank you so much. I invite Dr. Farr Nezhat to introduce the keynote speaker.
Thank you. All the speakers for the last very interactive session. It's my true pleasure to introduce to you our next keynote speaker, great friend, colleague, and mentor, Antonio Vintzileos, that I had the pleasure to work with him in Long Island Roseman Hospital for years, that he was chairman for 50 years. Dr. Vintzileos, right now, he's a professor in North Shore Hospital. He's the chief editor of the, deputy editor of the great journal. He has published more than 400 peer-reviewed papers and book chapters, books that I don't have to explain to you. But one of the bright things about Dr. Vintzileos is that he never refuses a challenge. 2 years ago, when we decided to establish a society, and we were looking at the literature, I came across about the possible complications of endometriosis, adenomyosis, obstetrical complications. And I discussed it with him. He is such an honest and bright person. He said, Farr, let me look into it. And then he searched and he came back with the excellent lectures that he's going to give it to you. And you will see that how much this endometriosis could cause problems with obstetrics.
Good morning, thank you very much, Farr. I guess several months ago, when Farr asked me to participate in this conference, I said, what should I do? I mean, you're all a group of great surgeons, some obstetrician, maternal-fetal medicine. During the conversation, the genesis of the idea of bridging the gap between gynecology and obstetrics came, that made me very curious. And really, adenomyosis and endometriosis are the conduits. Think about this, what I'm going to tell you right now. Obstetricians are very simple-minded. Think what we've done throughout the years. Adenomyosis and endometriosis are the only diseases that traditionally stop to exist during pregnancy. Have you ever thought about that? Have you ever thought about the idea that perhaps endometriosis and adenomyosis take different forms and clinical manifestations when you're pregnant? Have you ever thought that perhaps the different forms that Sina Nezhat mentioned in the gynecology, pain type, infertility, subtype of pain, have you ever thought that perhaps the same happens during pregnancy and people with endometriosis and adenomyosis, then due to the sterile inflammation they have, which could be all over the place in terms of burden, in terms of location, can then clinically be manifested with premature labor, premature rupture of the membranes, pregnancy-induced hypertension, preeclampsia, UGR, apraxia. Whoa! These are all the entities that are very challenging for us in obstetrics. These are number one entities that cause morbidity and mortality. Well, some disclosures that have nothing to do with the subject I present. These are the two echo bulletins up diagnosis of endometriosis. They came this month, 17 pages document. I'm sure many of you read it. If anybody saw the word pregnancy in this document, you let me know. As a matter of fact, the reason they made this document was just to change the diagnosis to a clinical one based on clinical symptomatology and physical findings in order to shorten the interval from initiation of symptoms to diagnosis. You all know how challenging that has been. I'll try to find where is the bulletin about adenomyosis. Nothing, I couldn't even find it. It was hidden into this diagnosis of abnormal uterine bleeding in a reproductive age woman, a 11 pages document, not a word about pregnancy. Why is that? Here is our obstetrical problems. All my career, I was trained to try to prevent those things. Preterm labor, preterm prom, preeclampsia, UGR, placenta. What are those things? Symptoms. What I mean by that? These are not etiologic related diseases. These are the obstetricians are described based upon what they see. We call it syndrome. Well, could they have a common pathophysiology with different manifestations clinically? The remainder of my talk, I would show you that I believe many of these women with endometriosis and adenomyosis present in pregnancy with this symptomatology. Very surprisingly, right now, since 2015, in the literature for endometriosis, there are 8 meta-analyses and 1 narrative review. For adenomyosis, 5 meta-analyses and 3 narrative reviews. These are not single articles. These are combination, right? And nevertheless, the SUG practice bulletins, as I show you, it didn't say anything about pregnancy. Do you see the gap? I hope you see the gap. Why is this gap? Well, most of this information is published in non-US and mostly non-obstetrical journals. In this world of specialization, we don't even talk to each other. Gynecologists don't talk to obstetricians, obstetricians don't talk to gynecologists, clinically as well as educationally, as well as discovery-wise. Bottom line, all those meta-analysis I show you, what do they show? They show that women with endometriosis and adenomyosis, when they get pregnant, they are at risk for preterm birth, preterm prom, preeclampsia, SGA, abruptio placenta, all this with asterisks. Asterisks because we call them grade obstetrical syndromes, meaning that are grade as far as the prevalence. And if you put those grade obstetrical syndromes, I would dare say it all together. Do you know what the rate is during pregnancy? About 10%. That 10% I've been seeing in your conferences, that is the percentage of women with endometriosis. And I believe most of them have adenomyosis too. But there are more other problems for these women. Placenta previa, postpartum hemorrhage, cesarean delivery, of course, because of the complications are increased. I want you to notice that the odds for adenomyosis much higher than endometriosis. Conclusion number 1. These complications may be related to the burden of the disease and how close they are to the uterine cavity. Because we're talking systemic inflammation here, foci, being close to the uterine cavity. But the obvious question is that, number 1, is the ART confined the adverse pregnancy outcomes, or is it really by themselves, adenomyosis or endometriosis? Associated with abnormal pregnancy outcome. Well, there is a meta-analysis for this from Langone, Canada, 33 studies, where looked at the association of adverse pregnancy outcomes in 3 groups of patients. Those conceived by ART, those conceived by spontaneous conception, and then combined the group. Well, here's the results. Preterm birth or stillbirth, endometriosis, again, for both groups, whatever you see, whatever odds ratio you see with the color, yellow is statistically significant, although those who are not, the relationship, the direction is one-way direction towards increased risk. Placenta previa, cesarean delivery, again, it's increased, the rate is increased, not only for those who have infertility and they come from ART, but also who have the disease without ART. And in addition, this paper showed that in addition to the trait of obstetrical syndrome, these women are also have increased rate of other pregnancy complications, gestational diabetes, cholestasis, malpresentation, dystocia, and of course, NICU admission and neonatal death because of the complications. Conclusion, both group of patients with spontaneous conception and ART, they are at risk for obstetrical complications. How about adenomyosis? Same. Here you see in the Hellenic meta-analysis that looks at preterm birth, preeclampsia, SGA, intrauterine fetal death for women who conceived with ART and they had adenomyosis versus natural conception and versus, again, combined the group, ART and natural conception. Regardless of where you're coming from, if you have adenomyosis, you are at risk for all these obstetrical complications. Same conclusion here as in endometriosis, that if you have adenomyosis, you are at risk for adverse pregnancy outcomes, either you conceived via ART or spontaneously. How about untangling the independent effects of endometriosis? This meta-analysis gave us an idea about the burden of disease. And I want you to see that endometriosis for preterm birth, very preterm birth, cesarean, placenta previa, endometriosis, you can see the odds ratios, 1 point something, 2.8. Coexistence with adenomyosis, look how higher those risks are. So now we have burden of the disease, agency with the endometrial cavity are very important factors for adverse pregnancy outcomes. As a matter of fact, for adenomyosis, you can see miscarriages and preeclampsia, the diffuse type appears to have higher rate of complications. Again, those associations were regardless of the method of conception. We also learn from population-based studies, especially from this one from Australia, that showed increased preeclampsia, placenta previa, and preterm birth. We learned that the preterm birth is not only for spontaneous preterm birth, but indicated both, either spontaneous or indicated, of course, because of preeclampsia and IUGF. So you're at risk for both types of preterm birth, and those were independent of ART use again. What is the pathophysiology? Pathophysiology is sterile inflammation. I heard what all the disease be all over the place, it's in the diaphragm, but imagine what happened to these women when they get pregnant. What do you think is going to happen? These women when they get pregnant. A few years ago, 3, 4, 5 years ago, it became obvious that one of the molecules expressed pathogenetically in both diseases, endometriosis and adenomyosis, is the high mobility group box 1. And you can see that is related to ectopic endometrium, high rates, and also for adenomyosis. So it is a pro-inflammatory molecule. It's increased in the absence of any microbial infection-related inflammation. So it's very important because that same and in both has been considered that it is a very pathogenic, very central role in the pathogenesis of both endometriosis and adenomyosis. I want you to pay attention now because this HMG-B1 3, 4 years ago was shown to be increased in endometriosis and adenomyosis. A few years earlier, a study that done by Roberto Romero had shown it to be present in cases of severe inflammation without microbial invasion. What you see in his picture here is part of this work. You see a Kaplan-Meier survival curve in women who came with preterm labor. He did amniocentesis and then sent the amniotic fluid for microbes. And he used a so-called electrospray ionization mass spectrometry to figure out what bacteria, if any, they were in. This method will discover for you any known bacteria, viruses that we know today, any human pathogen. He was looking, and all his life, he's been looking for these microbes or viruses causing this inflammation because most of the amniocentesis would reveal inflammation, high interleukin 6, but no microbes. And the thinking has been in obstetrics, there are microbes that we cannot culture, we don't have the culture techniques. Probably wrong. So in this study here, you can see basically that this group, blue, there was no inflammation. You can see this woman went the longest. This group had the molecule I mentioned before that's pathogenic in the role of endometriosis and adenomyosis, HMGB1, less than 8, it went less. The duration of pregnancy lasted less. Look at the green group. The green is the one that has the highest level of high mobility group box 1, the molecule that is coming from endometriosis and adenomyosis tissues. And that one did as bad as the red line. The red line was the group of women that had microbial invasion in the amniotic cavity. They have infection, basically. Well, now we start seeing that something very important. These are the groups there, the columns that the woman who delivered prior to 24 weeks, different gestational ages. Bottom line is that the blue, all the shaded blue areas are sterile inflammation. The red is microbial invasion. And I want you to remember this because I will show it to you again. And I want you to see 50% of them, that when I put a circle there is overall preterm birth. From the overall preterm birth, a third of them had sterile inflammation, no microbes. 14% less proportion, microbial invasion. And about half had nothing, none of the above. Up to this point, nobody has put any word about for that group. I'll get back to this. So what do you see here? You see here something that's revolutionary in terms of obstetrical thinking. Throughout the years, we thought that the ascending infection causes inflammation through bacterial invasion. So the bacterial invasion has to occur first in order to cause inflammation. If that was the case, then the microbial invasion part, the proportion should be higher, not lower. Here we see that most likely sterile inflammation comes first, teleologically is the biggest proportion, and microbial infection most likely comes second. And here is that the likely pathophysiology. We have adenomyosis and endometriosis. We all know that produce HMGB1. This is a pro-inflammatory mediator. It's a cascade, starts with binding on immune cell receptors called an amnion, will give you premature rupture of the membranes. Cytokines will come up, an inflammatory process goes to preterm labor. Sterile inflammation, I show you the percentage of women who had preterm labor and delivered preterm, 33% of them have it. And another 14% have microbial, which I believe is secondary. In other words, they get sterile inflammation first, and they are predisposed. Sterile inflammation predisposes you for microbial invasion. Why? There's plenty of literature to show that increased susceptibility to microbial invasion is something known, and therefore this kind of thinking now starts changing our obstetrical thinking. And application to other obstetrical conditions. We have preterm labor, we have a second trimester miscarriage, we have cervical insufficiency, we have second trimester short cervix, idiopathic vaginal bleeding and PROM. All these groups clinically defined, right? We have no idea what the underlying process is, but when you do amniocentesis, and the references are there, I want you to notice that the proportion of patients with sterile inflammation is much higher than the proportion of patients with infection, with microbial invasion, which means again, sterile inflammation comes first. What comes to my mind? HMGB1. What comes to my mind? Adenomyosis, I have to say, and endometriosis. The story continues here that some investigators, Roberto Romero's group actually, have dared to treat with antibiotics patients with intraamniotic inflammation, patients with cervical insufficiency, and also patients with idiopathic vaginal bleeding. And these patients actually have a better pregnancy outcome despite the fact they had no microbial invasion in the endometrial cavity, just by giving antibiotics to sterile inflammation patients. Why? Simply in my opinion, the antibiotic treatment is effective in that setting because prevents secondary microbial infection. Let's go to the IUGR. Let's go to preeclampsia. We all know that defective myometrial spiral artery remodeling throughout the years based on placental bed biopsies is the sine qua non of preeclampsia. So, but we have also some indications in the animal model as well as human that defective myometrial spiral artery remodeling is a cause of major obstetrical syndromes in endometriosis and adenomyosis. What's the pathophysiology here? The pathophysiology is, again, we start with chronic inflammation, and you can see the pictures there. That is associated with changes in JZ zone, absence of natural killer cells due to progesterone resistance. And this inflammation causes basically defective deep placentation with different degrees of defective remodeling of the spiral arteries. You can see the arrows points to a spiral artery that is defective remodeling as opposed to the one on the left that's supposed to be normal, and the histology. What is the result of different degrees of defective remodeling based on placental bed biopsies? It has been shown that when you have absent remodeling, you have preeclampsia. When you have absent remodeling in obstetrical lesions, you have preeclampsia with IUGR and abruptio placenta. When you have partial, when you pay attention here, when you have partial remodeling, then you start having IUGR without hypertension, preterm labor, and prom. Wow! So the different degrees of partial versus total remodeling or lack of remodeling will give you different clinical manifestations. I want you to pay attention to the last one, partial, because that partial basically is going to be perhaps responsible for explaining that wide proportion of no cause in women on preterm labor, because if you have a partial lack of remodeling of your spiral arteries, you're going to have preterm labor. And to me, my mind goes into the groups that I showed you before. The blue one has stellate inflammation that goes to preterm labor. The red one, microbial inflation. But who is not telling me that this is also coming from that mechanism and is related to ischemia? And we all know that about a third of preterm babies that are born even after spontaneous preterm labor, we know they have growth restriction. Now, you love this uterus, right? Beautiful. Imagine that uterus get pregnant. I think this is going to do well. Well, this one has a little bit of focally irregular junctional zone. What do you think about this one? Global interrupted junctional zone. What do you think if pregnancy goes into that uterus? I want you to look at that picture and tell me what you think is going to happen. I believe that uterus consists of fetal environmental hazard. It's full of sterile inflammation. Let me go into and there produce a new terminology, iatrogenic adenomyosis. Now, in obstetrics and in general, we have the opportunity to prevent things. Here, the obstetricians have the opportunity to prevent adenomyosis. Why? Throughout the years, we've noticed in the articles to show that there is association between increased cesarean section rate and adenomyosis. Well, this is, however, appears to be a bidirectional relationship. Of course, if you have adenomyosis, you have an increased chance for IUGR preeclampsia, you have increased chance for cesarean section. Now, start from cesarean section. Can you just because you have a cesarean section, then that made you to have adenomyosis? Answer, yes. Now, obstetricians, they go bites, they close the hysterotomy, they include the endometrium, as you all know. Look what they do. Look what they do. Look at the picture. That's a hysterotomy after closure. You see endometrium is looking at you, right? Is looking at endometrium, is looking at you. What do you think is going to happen to this endometrium when the woman starts menstruating? This is going to be a myometrial defect. It your literature is full of this myometrial defect and the theories that that defect causes problems, causes dyspareunia, causes all of a sudden the women who even didn't have a problem now have problems, and sometimes if you guys go and you take that scar tissue out, correct? Have you ever thought that you might have adenomyosis there? Have you ever thought that perhaps that kind of a closure is creating adenomyosis and perhaps you can prevent it? Here is a fascinating article from Iran that really took basically histology. They look at histology of the scar tissue after cesarean, and you can see that the residual myometrial thickness that we see in the ultrasound, and we think it's muscle, and we measure muscle, no, it's not. It's full of adenomyosis. As a matter of fact, in that particular study, adenomyosis was detected microscopically in 73% or most of the patients where the hysterectomy specimens, the rate of adenomyosis was 50%. However, in the scar was 75. We are really creating adenomyosis. I call it the iatrogenic adenomyosis. How you want to avoid it? It's easy. We have to stop being lazy and take those bites that we include endometrium, and there is articles here now coming out. 2 months ago, we had the cesarean supplement in the American Journal looking at hysterotomy closures. Endometrium-free closure appears to be the only way I can think of that you can avoid the so-called iatrogenic adenomyosis. Now, obstetricians may be mad at me because of the term I use, but I could not use a better, more descriptive term to push them to not hurry up and close the uterus the way they do now. We all know that there is a disease overlap. As far as obstetrics is concerned, whoever has adenomyosis is endometriosis and the other way around. And there are studies to show the great overlap. So if obstetrically we are going to go to an era where I'm going to say, let's evaluate the burden of the disease and the location and then prospectively study during pregnancy, this is what I would use. That's Cameron and Nezhat's classification of the disease. And when I saw this, I called Cameron and I said, I had a few conversations. And obstetrically, this is the only thing that makes sense. Encompasses endometriosis, adenomyosis, recognizes the overlap, and if you're going to help your fellow obstetricians, obstetrically speaking, that's the one to use. If you care about postoperatively how well they'll do and if the pain goes away, you may go with your partial classification schemes that I see, separate for endometriosis, separate for adenomyosis. Everybody's got their own scheme, depending upon what the outcome of interest is. I'm not saying it's about scheme. All I'm saying is, if obstetrically we're going to really prospectively study the outcome of this woman, that's the kind of disease burden location we should be documenting. Take-home messages, I don't want to say this again, education is very important. I believe the great obstetrical syndromes, many women with those symptoms do have endometriosis, adenomyosis. I would go as far as saying the reverse. What's the reverse? The reverse is, as you know, many women with endometriosis, adenomyosis are not diagnosed. The reverse means to me that if a woman during pregnancy develops one of the complications I showed you, why not screen for endometriosis, adenomyosis? And it's very hard to change the brain of the obstetricians when, especially the older ones, when they were taught that adenomyosis is a diagnosis that can be done only histologically and hysteroscopy, hysterectomy specimens. That's an anathema. It has been an anathema that is chasing us and make us unable or unwilling or not thinking about study this prospectively. So summarize, endometriosis, adenomyosis are conditions, as you all know, we don't need to tell you, of sterile inflammation. Sterile inflammation during pregnancy will create a great obstetrical syndrome with preterm labor, preterm prom, second trimester miscarriage. Sterile inflammation also causes impaired perfusion and placentation, as you know. I will give you preeclampsia, UGR, abruptio, fetal death, and some more goodies. Placenta previa, postpartum hemorrhage, and other pregnancy outcomes. So, few messages. One, endometriosis and adenomyosis do not cease to exist during pregnancy. I think we have to, traditionally, actually, a lot of obstetricians still say, if you get endometriosis, get pregnant, you feel better. I never thought that perhaps when you have cramps in the non-pregnant state, those cramps may become painful uterine contractions and preterm birth. I never thought that if you have abnormalities in your menstrual flow, that perhaps during pregnancy becomes idiopathic vaginal bleeding, which leads to preterm birth. I believe the conditions are fetal environmental hazards. And I also believe endometriosis and adenomyosis provide a great opportunity to bridge the gap between gynecology and obstetrics. Zero. Thank you.
Thank you very much, Tony, for our outstanding talk. We have a few minutes for a few questions before we go for lunch.
Make your question short and sweet because we are half an hour behind the schedule. But before you ask your question, an announcement we have to make. We have lunch and learn tables available. And for some reason, we have a couple of spots available. So go to Azure 2 if you are interested, and Zoe would sit you based on first come, first serve. Thank you.
Thank you so much for that amazing talk. I have two questions. One, since so many of us see women who have endometriosis and adenomyosis, and most of them want to get pregnant, would you recommend any type of prenatal screening, knowing this increased incidence of complications in this group, and what type of screening should we be doing obstetrics?
Excellent question. I think the answer is yes. Right now, in our books in obstetrics, we consider IVF as a risk factor for adverse pregnancy outcomes. And however, they are not so much keen into doing too much for those IVF patients, other than they are in general at high risk for premature labor. We don't do too much about that, but we do, and I think it's been recognized as a cause of bleeding, meaning a risk factor for hemorrhage. And it's one of those factors, not in all hospitals, not in all tools. It's been used as a little bit of a risk factor in terms of postpartum hemorrhage or placenta previa, and that's it. Now, some of those IVF patients, they are hidden, some endometriosis, adenomyosis in there. If you have the history, of course, I think, in my opinion, I think they should have surveillance. Surveillance combined. What does that mean? You are at risk for preterm labor, which means, first of all, you are at risk for preeclampsia to start with. First trimester evaluation or assessment of the preeclampsia risk. There are many ways to do that. The SUG way that has a very low sensitivity because it's going to be based on clinical factors. And there is a more, the European way, I would say, that involves maternal factors, history, uterine artery Doppler, and also biomarkers, placenta factor, and PAPE, and you got your individual risk factor for preeclampsia. And if your risk is more than 100, more than 150, you go to aspirin. Then you're also at risk for preterm labor, which means you have some lengths of the cervix being evaluated. Everybody's got a second trimester sonogram for fetal anomaly survey, but not everybody has a cervical transvaginal sonogram for cervical length. I believe these women are at risk for preterm birth. They should have transvaginally evaluated cervical length. And of course, IUGR, all this there. And when it comes down to IUGR, clinically, we're not very good with our hands. With our hands, we miss 2/3 of IUGRs. What does that mean? An extra ultrasound around 28 weeks, 30, and another 36, 35 weeks for surveillance. And as I mentioned before, I think pretty much we have to treat this as high risk for both preterm labor as well as preeclampsia.
My second question was just, do you think this is responsible for the racial disparity in maternal mortality?
Excellent question. What a good question. Actually, to be honest with you, I was feeling the same question this morning when I was listening to some of the other lectures. One of the speakers, I don't remember who, had put a slide about socioeconomic class, and of course, 10% are diagnosed. I have not seen. You should know better. What's the rate of endometriosis in the different socioeconomic classes? I mean,
Racially, it's higher in Black women.
is what?
There's a higher incidence of adenomyosis diagnosed in Black women.
Oh yes. Okay. So it makes sense, and I can tell you this: I don't believe that 10%. I know that you say 10%. I think 10% is because you're not diagnosing them, right? And I can tell you, each time I look at the cervical lengths, sometimes they include just the cervical by via transvaginal ultrasound, the picture. And if somebody gets a picture of the upper segment above the cervix, the lower uterine segments, invariably I see holes. I see a short cervix, and I see lesions of adenomyosis that nobody pays attention. Obstetricians don't pay attention to the myometrial walls. Obstetricians will do first trimester screening in pregnancy. They will focus on the nuchal lucency here, as there is nothing else exists around it. The crown round length, myometrial walls, they don't really care to see what's in there. And I can tell you, there are many cases of adenomyosis out there. And if you talk to people who do, let's say, part of their work is a big number of women with recurrent pregnancy losses who end up having abdominal surplus. And those surgeons know ultrasound, and they do their own ultrasound. They will tell you almost all of them have adenomyosis. What are this group of women? The one that has, lost 1, 2, 3 pregnancies and have failed vaginal surpluses, and they end up with a minimally invasive surgeon who knows how to do his or her ultrasound. They will tell you most of them have adenomyosis in the ultrasound because they do their own ultrasound. They know what to look for. So I think the disease is, and especially I know surgically you guys are paying attention to endometriosis because it is more tangible. You can see it, you can excise it, and of course adenomyosis is not so much accessible surgically unless it's a big adenomyoma, and then of course, but if you look at the studies too, you can see there are many more in endometriosis than in adenomyosis. I think it's the same disease. Obstetrically, by the way, different locations. We heard it this morning, and that's why you get these different manifestations. I like seeing on the subtypes, the gynecological subtypes, the pain subtype, the infertile subtype, and I just show you the obstetrical subtypes with this lecture.
Thank you very much. Go ahead.
go for the lunch.
Yes, 1:15, go like